Kim, you made it?
Made it. I'm really sorry.
Don't be sorry.
We were talking about Ben's premiums.
Yeah.
Oh, no.
Yeah, we were talking about my my insurance going up, and so I posted about it today on LinkedIn because I was like, I got my notice on Monday that my insurance is going to go up. So mind you, I've been on the marketplace for 8 years, so I got because I was self-employed, so I just get mine directly off the marketplace. And last year I told her it went from $1,700 to $1,900. So I told Tina so that was a pretty big increase, but I was like, okay, that's not great, but okay. This year it's going from $1,900 to $2,500. It's going up 30%. So in 2 years, it's gone up 50%. I'm like, how is that possible?
Yeah, well, welcome to the ACA, right? It's like
It's unbelievable.
And the big beautiful bill.
Well, I think that's I would assume that's the bigger culprit. I think there's lots of factors. I'm not blaming it just on that. I think that it's really kind of unbelievable though that get handed down. So I can't tell if Blue Cross Blue Shield of Michigan, I'll just say it, is trying to get me off the rolls, and they're just like, well, we don't want anyone on this marketplace plan, so we'll just increase it so high you have to go choose something else. I don't know if it's that or it's literally just handing off all their costs to people who may not be able to push back on it. I can't.
I think they're just increasing.
Really...
I think, Ben, they're just increasing it to everybody. I think they're just looking at their population. And by the way, just a sec. I purposely do not want to wear these earrings in case, depending on when you air this season.
Wait, what were the earrings? Oh, Halloween.
Well, they're Halloween.
Yeah, we're probably going to be in January.
Nice.
That's right.
We're in the work.
The rate we're going.
Yeah.
Kim, you got a little maize and blue up there. I like it. A little Michigan helmet.
Is always in something that I'm doing.
We lost her.
No, you didn't. I'm at the other
side. Oh, there she is. There she is.
There you go.
You did not lose me. That is, we go to all the home games. We're big Michigan fans.
You go to all the home games?
Yeah. My husband's had season tickets for 43 years, I think.
Well, that's right, because you're in Kalamazoo or Grand Rapids.
I was not born, raised in Grand Rapids. I was raised actually on Long Island. From Grand Rapids, went to Kalamazoo College, kind of the tour, got into Michigan 3 times, never went. My dad was like, really? I'm like, not going. Sorry. Didn't have the nuclear
But
physics
that's when
program.
it was like $50 to apply to college or something, right? Or there was no fee?
It was like $15. I was like, nothing.
Yeah,
$15.
Nominal.
Yeah, I was like, it wasn't much.
I was nominal.
Yeah,
right. Like he was funny because I have a master's in nuclear physics. I think Christine told you that, Ben. That I worked on my PhD at Emory, and then I was like, what am I doing? These people are weird. And I wouldn't say that publicly, but I mean,
you are saying it publicly,
I know,
but it's
I am
fine.
Technically.
It's so long ago. They don't know. No one's listening to nuclear physics.
So I worked in it for a little while. I taught it for a little while, but I ended up accidentally becoming a health system CFO. Go figure. Nothing more complex than taking care of people.
Well, you might as well start there, Kim. You kicked us off. So why did you go to nuclear physicist?
Why was I nuclear physics? I was just really
what did you like? Hey, I got to go into this. How did you land on that?
I was really good at it. Figuring out complex things and how things interact was just like one of my fortes. I was like one of those math, computer science nerds too, and so it was just one of those things I was just really good at. And I was working. My master's thesis is hypernuclear photoproduction. Yeah, you're going. So it's actually slamming 2 particles into each other, and what type of reaction do you get when you're done? And my cousin actually proved it on the accelerator he was working on in Europe, and so it's kind of nice that way. So
I guess. I mean, my cousins aren't doing anything like that, but okay.
No, he's a nuclear engineer.
Yeah, clearly.
Yeah. So I worked on my PhD at Emory, and then I was like, I don't really want to do this. It was probably the first time I felt I was going to disappoint my father, who is a surgeon. I came home and he says, that's not what you want to do. What do you want to do? And I go, I don't know. So taught physics and got an MBA. I hooked up with a guy who had a PhD in chemistry and finance. And so I will have to tell you, going to a liberal arts school, it didn't really prepare me for what I was going to do for a career. It just really prepared me to keep going to school, and which is fine because I kept going to school. But I slowly, when I needed to get a job in northern lower Michigan, which, as you would know, Cadillac, Michigan, the CFO for Cadillac and Grayling Hospital said, if you can figure out physics, you can figure out healthcare finance.
Wait, he
And so
hired you direct out of like you didn't even have an MBA at this point, right?
I had an MBA because I was working in banking and corporate trust. I think
Oh,
we
I
all
see.
start in banking if we don't know what to do in business.
Wait, so how did you get from Long Island to like Grand Rapids? I mean, it's not the obvious choice.
Well,
how did you?
So that was as a child. I was adopted. My father was in the Navy. He was a surgeon in the Navy. And he was based on Long Island. And my brother, 6 years older, they couldn't get pregnant, so they decided. My dad said, "Let's try and adopt." Which I carry that around with me every day. People always wonder what this is on my wrist. This is the adoption symbol, if you can see it. It's a triangle represent the two sets of parents and the child intertwined with love, which is a heart, and that represents the love my parents had.
I did not know this, and both my girls we adopted both my girls, right? I don't know.
Oh, I didn't know that.
Yeah. So, but I'd never seen that before, so that's cool. I never knew that symbol.
The adoption signal. So I think it's really a black triangle with a red heart. But when my father passed, I decided I wanted something that was close, that I could see every day, that reminded me of the joy with him, and that he was my father because he was the one who suggested the adoption. So I was adopted. The interesting part is then they got pregnant with my sister. So,
of course
we're less than a year apart.
Well, that's awesome.
Yeah,
that's
very much different, but we are best friends.
Both my kids are very different. So
yeah, very different.
What do you know?
So that's pretty much how he did his residency at Henry Ford, where his father was head of OBGYN at Henry Ford, actually an internationally renowned OBGYN. My father's an ophthalmologist, and he set up private practice in Grand Rapids. So that's kind of
that makes sense. Yeah, that makes sense.
Back.
Wow.
Yeah.
So you ended up at K College, you did undergrad at K College, and then graduate school at Emory.
Nope. Yeah, master's degree at Western Michigan, actually.
Western Michigan. Okay.
Terminal masters at the time, and they had an accelerator under the green grass outside the physics building, so that nobody really knew was there, but they had a small accelerator, also affiliated with Argonne outside Chicago. Got my master's. That was the hypernuclear photoproduction, which, by the way, you can find in the Annals of Physics if you're ever sleepy.
Wow.
And read that.
Or if you're not sleepy and you need to get sleepy.
Yeah, exactly.
No. I'm sure it's riveting.
Well, I'm sure it is.
So yeah, Dr. Rosenthal and myself, and we had fun. Halverson.
That's so funny because I used to live right near campus at Western. Yeah.
Did you go to Waldo's then, I'm assuming?
What's that?
Did you go to Waldo's?
Oh yeah, Waldo's. What about the pizza place?
Oh yeah, I know what you're talking about.
It's named after the Lord of the Rings. Oh, Bilbo's? Is it Bilbo's?
Bilbo's, yes.
Yeah,
we went there too. But Waldo's was always interesting because upstairs were the Western students and downstairs were the K students. So it was it was a bar right between our two campuses.
We live almost on campus, a little Arcadian neighborhood. It was right there. Yeah. So crazy that we were right there, but all right, small world. So then you got your MBA. You ended up in Cadillac of all places, where most people listening to this don't know where that is, but it's northern Michigan, but not really. So
right here.
It's
kind of
halfway in between.
Right here. So I always tell people do the hand thing. You guys from Michigan
bring out the map.
hand thing.
I love it, of course.
I don't know how other people live in other states and they don't have a handy map.
I guess Florida can kind of do it. You're
no, they really, because you got the panhandle.
Yeah, it doesn't work the same.
You got to go the other way.
You got the little panhandle.
Yeah. Yeah, but
no, Michigan's the best because I'm always and they're always okay, that's funny. I'm no, really, it's you go here to here.
Exactly. exactly. No, I'm the same way when I worked out in the Pacific Northwest. They're like, "What are you doing?" I said, "Well, this is what Michigan looks like. Do I need to show you on a map?" And they're like, "Well,
Yeah,
can
come on.
you?" And I said, "You're right. It is a hand." I said, "The Lower Peninsula."
It's a
Because
mitten.
actually, you know this, Ben. When you say Upper Lower Michigan, people look at you like, "What are you talking about?" You know, but
Oh, we do.
yeah,
Yeah,
yeah.
we do.
So yeah. So I Cadillac and Grayling, part of Mercy at the time, before it became part of Munson. But it
Right.
was
Yep.
part of Mercy before Mercy became Trinity.
Yep.
So my first 5 years, I call it we didn't have residency and fellowship programs back then. But I call it my 5-year residency program, where I got to figure out that medical records was just not filing charts. I got to observe surgery, got to implement decision support. I was actually, I think, one of the beta sites for the Kaufman Hall and Nuff model. I worked with Jason Sussman on implementing
Oh my
the
gosh.
Lotus
Yeah.
model when it was one page and you had to build it in square blocks. Remember, you had
Yes.
square, square, square. So when you added rows and columns, you didn't disturb the calculation.
I was on Lotus 123 probably.
Hating myself. I remember when it moved to Excel, I was mortified.
Yeah, you're like, this sucks.
Only the keystrokes.
Yeah, what is this? I did. I worked on Lotus 123. I know.
Yeah.
Trust me.
Yeah. So that was fun. That was 5 years though of really, those are PHO days. It was rolling your sleeves up. And I had a lot of great people. And then I had the system CFO was Jim Combs at the time for Mercy. And he kind of took me under his wing. And so I was actually fortunate to do some system projects. I also got to go to American Samoa and do one of the Mercy International projects. That was quite interesting. I went for 3 weeks to put a budget together for
Wow.
American Samoa, which, as you know, is a U.S. territory. However, they have 2 hotels at the time. One was by the hour and one was by the night. I stayed by the night, of course.
Probably a good choice.
Every morning when I got up in the car, I had to go boom, boom, boom on the seat to make sure all the little bugs got out of my car before I got in the car.
Oh.
That was also an American Samoa.
Tina's cringing at this.
I know.
That's not
you
for
know,
me.
when you land
That's not
there,
for me, Kim. You're a
only
braver woman than I.
I'm sorry, Tina. When you land there, the airport is like the social event. You can come in from Hawaii like 2 days a week at the time, and you'd come in on Monday and you could leave on Fridays or something. You just couldn't get off the rest of the time to go back to Hawaii. And so it was like a social event. People were there at the airport, took off or landed.
Yeah.
When you landed, though, you landed at the end of the runway. I think you had like maybe this much room before you fall into the ocean. So it was quite fun. It was a different culture. American Samoa at the time produced 25% of the tuna for around the world for chicken of the sea and starfish, yeah. So at the time, so they had 2 plants and they'd bring in the tuna, and if you drove between the plants, which we did almost every night, and I'll tell you why in a minute, it stunk.
Oh, I can't even imagine.
It stunk. And the reason we would drive by is there was a little
Tuna
mini
plants.
bar on the beach with no
Yes.
electricity. She would haul in the ice called Tisa's, and we would go there
What?
every night after work and have a drink until it got too dark and we couldn't be there anymore. So, yeah,
That's amazing.
we had a great time. It was interesting. They are definitely healthcare not delivered the way they had medical officers there from New Zealand. They were in training. If you happened to be the second half of their year, you might not have drugs when you were delivering a baby because they ran out of the budget to pay for the drugs for you to deliver the baby. And so if you're on a unit as an inpatient, you would have LPNs taking care of you, not RNs, and no really ratios. So it's just a different care. We, though, had at the time about $3 million of off-island care where we were paying for people to go get an MRI in Hawaii because it was a 5-hour flight, but that's the closest place to get an MRI or to have, surgery. So we had off-island care.
5-hour flight from Hawaii?
Mhm.
God, I actually don't have any idea where American Samoa
So American
is.
Samoa is just this side of the date line, but just south of the equator. It's in that little corner if you were to draw the equator and the date line. So just this side of the date line. So it's kind of in the middle. Philippines, you might think are closer.
Yeah,
they probably
so
are.
far. Right.
But because it's a U.S. territory, the off-island care often went back to Hawaii. And then
Yeah.
you weren't just flying the patient, by the way. You're usually flying their family member with them. So it was a great experience putting that budget together. I was there. The CEO and the chief nursing officer were also part of Mercy International, so they were also there. So it was kind of nice to have a little bit of a team, um, just to kind of show you around. But it was 3 weeks. It was fun, great experience. And then I actually then went to Grand Rapids to work at St. Mary's, so which was also part of Mercy.
So when
So.
did you get your first CFO job? Like how did that happen? Like what was the
So I was working for Ascension. So first I worked for Aurora. Well, I had a couple bumps, but I went to Aurora and I was the executive director over finance and compliance for Aurora Ventures. But I reported to the president. The divisions had basically executive directors for their business lines at Aurora. And so I had a great time there for about 8 or 9 years in the retail space. So I had 150 retail
Mm-hmm.
pharmacies at one point. I opened up, was it 13 or 15 retail clinics from scratch? Worked with Walmart on their pilot. We did 7 stores with Walmart in Wisconsin. It was pretty fun, but it was nice to see the other side of healthcare and where others were trying to get in the healthcare space that had no idea how complex it was on the financial side of healthcare.
Sure.
Not the delivery of healthcare. It's not, it's just the financial side of healthcare is much more difficult in the regulations.
Right.
Then I thought I should go back and get back with the system. So I went to work for Ascension in Milwaukee. And then they asked me to go to Evansville, Indiana as the CFO. So my first true titled CFO job was in Evansville, Indiana with Ascension.
Did we run into each other then? I mean, I feel like I looked at your LinkedIn bio and I was like, so many relevant areas.
Yeah,
I'm trying to think.
we
You
could
wouldn't have
have.
known because Kim, her last name's Wargle now, but like, a really good friend of mine was the CFO there at Evansville.
Really?
Still lives there. Yeah, still lives in Evansville.
You might have been maybe after my time, maybe.
It
I don't
probably
know.
was, yeah, or maybe before. I don't know.
Yeah, I
That's
was there
interesting.
before it was Ascension, Indiana. So there was Ascension in Indy and then Ascension in Evansville. And one of my roles was to work with Vince Capone, who was the CEO in Indianapolis at the time, around integration of like the back office stuff. So how do we integrate revenue cycle? How do we look at some finance things? How do we look at the IT department? And so how do we integrate starting that motion towards Ascension, Indiana, but starting with the back the support services?
That was before like the accretive like world, right?
No, I had a creative in Milwaukee when I was with
In
us.
Milwaukee, but you didn't have it in Indianapolis during your time.
Kicked him out. Sorry, did I say that?
Yeah, well,
Terminated
eventually it
with
all
That was
came back
fair.
together. But yes, I know the area you're talking about.
Yeah, so they left, and then we integrated with St. Vincent's to do revenue cycle management with Phil Skinner and Kevin. I want to say Combs, but it's not Kevin Combs. Kevin's last name is escaping me, but he was great. So I see him from time to time. So so definitely that. And then I had a creative again, and when I went to Jacksonville as a CFO for Ascension. So
You went to Jacksonville?
yes, I
Oh
did.
my gosh. What years were
Every
you in
year.
Jacksonville?
Oh, McAndrews, by the way, is the guy from St. Vincent's that I worked with. See, he was great. I see him occasionally. But I was in wow, you're gonna test my brains. In Jacksonville, I left in 16, so it would have been 14 to
Oh, this
16.
is way after, yeah. Okay.
Yeah, and then a couple years in Evansville, a couple years in Ascension. So Ascension, I also was in the Leadership Academy for Ascension when I was in Jacksonville. So, which is fun. It was an immersion program for C levels with still room to move in the organization. Um, that actually focused on, of course, the mission and Catholicity, as well as leadership, change management, and then we had a corporate athlete component. So, so that was a great program. It was about 2.5 years, once a quarter. Also did some projects. That's when we had about 18 people. You bring them together, and the titles don't matter. and it's a great learning experience. You get so many people, titles don't matter, how are you working together? It's such a great reminder that team sports are fun.
Yeah, for sure. That's good. So how did you end up leaving Ascension? So like fast forward, get us to today. Like how did you like what's the track to like what you're doing today? Because you're on your own, but kind of working now I mean, or
I'm
explain what it is that you're doing now
Yeah,
today.
yeah. So it took I've been a CFO for a system. So at the system level, I've been a CFO at the market level. A couple journeys during COVID. I went back to Trinity during COVID. I had moved back to the Midwest because my father got sick, and so I moved back to the Midwest and worked through COVID. That's where we kind of probably re-engaged, getting to know each other through the connections there, and then. I actually, for the last 2 years, 'cause my father, another story, he got sick again. And so I took time away to spend time with him before he passed away last year, which was great. Time I cannot get back. But during that time, I was doing consulting and I did it in 3 ways. I actually have been doing national speaking around for women. My theme is kind of light your candle first so you can light up the world. You see that on my LinkedIn page. It's kind of my
Yeah,
mantra.
very good.
I got certified as a chief AI officer, knowing that as we move forward, my wisdom I've gained over the years is great, but I need to actually continue to learn. That's always something I love to do. So while I can't make the sausage in AI, I certainly know how to use it, what we can do with it, tools. So I've been training executives on how to use AI as a tool to really get them excited around this is a tool that is powerful that really can help in so many ways, just even in your daily life for your leadership. And the third, I was doing healthcare consulting around whether it's finance. I worked with an FQHC. I've worked with some hospital systems. And today, I actually have gone back and I'm the CFO actually at JPS Health in Fort Worth. So I've been
So
here
you
about
took a full-time CFO role again.
I did, but I'm still having some fun outside of that with
Oh,
the
good. Okay.
speaking and the AI. And I have some gentlemen I work with, Winding Lane Management. I'm the CFO for their consulting company around basically urgent cares. So I have a little kind of things I do, as what my husband calls, in the evening. So,
Hmm.
but I think healthcare is a great space to be. I mean, it is never changing. It's always a challenge, and I think that I'll be doing this for a long.
Yeah, very cool. So when you got time to step away with your dad, walk us through a little bit of that. Like, because that's something I think people talk about or they talk about wanting to do, but don't do. And I'm sure a number of people listening to this would resonate with it, but also like my age group was of parents or Tina's age group that parents are getting older
Hmm.
and getting to a phase like this. I don't know, this maybe go a little deeper on if you're willing on like what it was like and what was your decision process.
Sure. I think, God does what he does. He has purpose and he has a plan. None of us know what that is. And, I was in another role. The organization decided to change my role, and that was not a role that I wanted to stay with. So I took the opportunity to step away, rethink, do I want to stay in healthcare? Do I want to do something different? How do I want to help? And then when my father got sick, I was like, you know what? I now have the time to spend with him and my mother because she was going through her own process of grieving and really walk him through until he passed. And um, my father was my rock. I'm going to get emotional. He was my rock. I miss him every day. That's one reason I have that reminder of him to walk with me every day, and I know he's with me every day. But the emotion, I think, if I hadn't been there today, I would feel regretful. And regrets are good. You can always have regrets and learn from them, but this is not a regret that I could relive. I couldn't go back. He's gone. I miss him every day. He was great advice. Even in his last days, when he wasn't as communicative, he was there. He, he could squeeze my hand, he could smile. So I tell people, take the time, make the time, because you're not going to get it back. You're not going to get it back. So figure it out. We all have vacation time. I always tell people, family first, make time for you. And back to my mantra of light your candle first so you can light up the world. This lit my candle. It refreshed my life, even though he's not here physically. He reminds me of the lessons I've learned along the way. So I just tell people, just you've got to take the time. Work will still be here. So I hope that helps. I
No,
can't
it's
emphasize
awesome.
it more. I mean, some people ask me, like, they have family issues. I'm like, you've got to take the time. Work will still be here. And you have to make the best decision for you.
I think in some people's mind, I think it's like, I don't want to see a parent in that stage. Do you know, like the dying stage? I don't want to ruin a memory of like what they could, but like. But I think your point is, it doesn't, like, that's irrelevant. You won't regret the time, even if it's not them. It's not the one you remember at the end, right? Like that to me seems like very profound.
Right. And it was hard to see him at the later stages. I won't lie to you. That was
Oh,
really
right,
hard.
right.
But I have pictures. I remember what my dad was like. I remember the interactions and the things we did together. And so whenever I start moving back to those final days, I push myself into the times I remember when we were actually doing things. So we hunted together, we hunted birds, we fly fished. I mowed the lawn. Oh yeah, I mowed the lawn. I shot trap with him. So we did a lot of, I call it the boy things together because I was a tomboy, tom girl, I should say. But we did a lot of that stuff together, and just remembering it, and I still do some of that stuff. And so he's just with me, and I tell people, just my dad's here today, or they're like, "What are you talking about?" And I go, "He's here. I can feel him." Because they'll always be part of you.
Yeah, it's super cool. Well, I'm glad you got that opportunity. It sounds like you said, wasn't intended in like the changing of the rules, but it feels like it all kind of worked, right?
Right.
Now you're back in, and now you're in for the easy part of healthcare, right? Like the easy times. This is the
Sure.
easy times. What do we call this?
I don't think this is the easy times. These are the changing
Okay.
times, I think is
Yeah,
what you want to call them, that. Changing times.
Yeah, that's it. That's it. All right.
Are you looking for a judgment-free revenue cycle space? Do you want to expand your revenue management skills and learn insider strategies? Check out RevCycle 101. Unlock the foundations of healthcare finance with RevCycle 101, a comprehensive course designed to give anyone, from a recent graduate taking their first professional steps to a seasoned sales leader refining their expertise, the clarity and confidence to excel in revenue cycle management. Through easy-to-understand terminology, practical tools, and proven methods, this course demystifies the complexities of the revenue cycle. It equips you with the skills to drive results, optimize operational efficiency, and significantly advance your career in the shifting realities of today's healthcare industry. Click the link in the description for more information. Now back to the show.
All right. Well, let's switch gears a bit. Like, let's talk about what we're facing. You're working at, my understanding is this a rural, this is inner city? Is this kind
This
of like
is
inner city?
600-bed community academic medical center, Trauma One in Tarrant County or Fort Worth, Texas. So county, different environment, politics, that
Is it
go
county
along with
owned
funding.
or
Pardon?
county owned or state owned or
It's
just,
special district of the county.
okay.
We also have the largest family residency program in the country. I think we're number 3. We're number 1 for the 3rd year in a row. So, very large, very busy. And we have a medical group too, by the way, that goes along with us. So,
All right. So lots of changes coming for you guys. Like, what are you anticipating for 26? What are you guys like? This is big beautiful bill happens or this stuff's happening, like what are you guys like? What's keeping you up at night? Is related to this because I'd be curious from your perspective on a very different hospital scene than some people are in.
Oh, yeah, absolutely. Fortunately, we are in a red state. And so the Medicaid impacts are not as great for us. However, we have internal Medicaid state directed payment challenges about going through how allocations are going to be done for certain programs. And so we're working through that with our local Texas organizations. But I think, I think there's a couple categories that I am worried about. This is a people business, whether you're looking at who we employ or who we take care of. Tarrant County in and of itself has 23% uninsured. We're in North Texas, but we do suffer from the open borders that have been occurring. So we have not lawfully present people here in Texas. So, I mean, they're all over the country, but we have a lot here. So taking care of the people who can't pay is a big challenge for us as we move forward. We're also in the middle of a master facility plan. We are replacing our hospital, building a medical outpatient building, doing some of that. It's a large next 4.5 years. Our journey is to get that done and to continue to produce operating funds to fund that. So it's a challenge here to take care of the community only from, I mean, when we look at funding and recruitment, right? You have to be here for the mission. This is a whole different group of people than you would see at an affluent hospital, private hospital. So people is really making sure that we can attract the labor. People here have been here for a long time working here. They love the mission, but we also know they have lives and we have to make sure that they can take care of their families so that they can come to work every day and take care of the patients we're serving. It's a big one. Labor is a big one for me. Training. We actually have a program called Shine that we do. We had a grant. It's kind of fun. It's high school students who apply. I think we had 30 students this year that went through it. They go through an 8-week paid internship, work in various areas. So we had 30 students. I think we had 600 applicants. I think that's right. And they graduated this summer before they went back to school. But it's a way to get people to learn about healthcare and in high school. And I have to tell you, I really didn't know the complexity and what was available in the healthcare space until I actually worked in it. So my father was in private practice, and there is so much to do here and so many paths for people to grow. So when you talk about one of the biggest issues is labor, I'm going to tell you, I also believe there's a bunch of challenges in the payer-provider relationships going on. It's just a challenge on getting paid for the care you're delivering, making sure it's fair. I think we both payer and provider have issues. And so how do we level that playing field and not just try to keep dinging each other? Tends to be the way it works. And then cyber is a big issue. I mean, with AI growing, we can't have a conversation without that coming up. With AI growing, it's a constant battle with the technology, the hackers, the people who want to do harm to our systems or gain from doing harm. Big issue, big risks. And people always ask me, well, it doesn't seem like the issues change very much. And I said, right now, it's people, it's payment, and it's security of our systems so that we can take care of our patients. Just the big ones. But what I'm finding here where I am is getting back to foundation is super
important. You said something around, we'll go back to some of the issues you just said, but like, I'd be curious to know, you said you're going to cover the new building with operations. So did you guys not do a capital campaign or a bond covenant? Like, did you do a bond to raise money? Like, how are you going to fund it through operations? Like,
so the county taxpayers have approved $800 million of debt, of which we've gone out for $450, and we'll go out for the rest of the debt in about a year. So about $800 million. This is about a $2.5 billion master facility plan, being funded from operations primarily. So that's where it's coming from. We we have about $1.7 billion that have been accumulated. Then we'll have the debt, so then we'll have about $2 billion. So we have about another $500 million to go. And we've fortunately been performing well in order to fund that from operations. And as long as the market holds,
cross your fingers. Saw that. Yeah, as the market holds. Well, that's impressive. I mean, that's not easy to pull off.
It's not easy to pull off. It's unique. The commitment here by the county commission was, and with the voters, was to not raise the tax rate in order to go out for this debt, which they have complied, and the tax rate has not gone up for the hospital district.
Interesting. So let's talk about payers. You guys have what's your largest commercial payer? Like, I don't know what's in Texas. Like, what is the largest?
We have Cigna and United. We have those friends.
Oh, okay.
And Blue Cross.
And do you have a lot of like Medicare Advantage in the area or Medicaid Advantage?
We do. Give me an idea. We're only about 20 to 25% commercial. So the rest of it is either self-pay, Medicaid, Medicare. Remember, our mission our mission is to take care of the residents of Tarrant County, right? And the people around. So if people don't have insurance, we're here for them.
And you get covered by, there's some state coverage, like not coverage, but you get some state funds to cover uninsured. Like, how does that work there in Texas?
So we have two funding sources out of the normal revenue cycle. We have the state directed payments, so the Medicaid supplementals payments that we get. So uncompensated care, DISH, there's a couple other special programs, but those are the two largest. And then we also get tax revenue from the county,
which is separate from the money you got for the building. Like, that's, you're not taking any of that funding. You're taking funding directly from the tax, which was probably put into place long ago, right?
Long time ago. I mean, I think Parkland, which is Dallas, and then JPS or John Peter Smith is Fort Worth equivalent. We have five safety nets in the state of Texas, and that county hospitals, I should say, 5 county hospitals. And so we all have county revenue that supports us.
What? I'm sorry, I'm asking like a lot of detailed questions, but it's such a unique setup. And I just facilitated this panel in Tri-State HFMA, which was, I had a CFO from Ohio, Indiana, Kentucky, and the way they described these different versions of payments was so different from each other. It's like wild. I was like, this is wild how different the states are treating all of this, which is all fascinating on a lot of fronts. So how is it working with like a county, like on your board? I'm assuming there's a board of the health system. Is the board county approved, like county dictated, or is it just the county executives? Like, how does that work?
So Tarrant County has 4 commissioners and a judge that run the county, basically, that are elected. And we have 11 board members, of which each commissioner and the judge each appoint 2, and then there's an at-large member. So they are political appointees that are the members of our board.
So is that, but I'd say the obvious, is it political? Like, does it get political?
I think if they all bring a different skill set to the table.
Or they stay pretty true to like, hey, well, this is like the mission here. It doesn't really matter.
I think it's both. I think they have alignment with their commissioner or the judge, whoever appointed them. And so they're aligned with them. Most of them don't have the direct healthcare experience that you would expect. And so some of our role is for them to understand the complexities of running healthcare and healthcare system.
That makes sense. It's fascinating. I don't know, Tina, what else you got? I'm trying to think of
well,
like what
I was just going to ask, I mean, Kim, you seem like obviously very interested in keep continuing to educate yourself and stay on top of the game, clearly with your focus on AI and just knowing that that's going to be something that is going to be a real tool for getting us to the future. But as you've gone from state to state, I was just thinking about what Ben had just said about those different CFOs. As you've gone from state to state, serving in these different communities, how much of a learning curve do you face every time you step into a new position?
So it's interesting because this role I jumped in at the end of the budget, right? So I'm preparing the budget, understanding the budget, having to present the budget. And some of the comments are, wow, you learned that fast. And I said, well, here's the issue. The issues are the same everywhere you go. The dollars are just different. And what you really need to understand is the culture of the organization, internally and externally to the organization, and then where they are foundationally as an organization. So that I'll say, do I need to fix the foundations? Do we need to move forward? And we're great and we're optimizing. I've been fortunate. Usually I end up not with just finance, but I have IT supply chain as areas of responsibility. And so what I find the biggest thing is the culture and how the organization is performing. But most organizations have similar issues. To your point earlier about every state takes these the federally funded IGTs and does them in a different way. Every state has been different in how they do the submission and what the programs are called and how they allocate. And so learning those is always a challenge too. So that's unique to the market or wherever I'm serving. So fortunately,
and you're probably correlating them to another thing, right? Like, oh, in this state it was called blah blah blah.
Sort of
drawing those connections.
But then they do it differently, right? Wisconsin did it great. I've worked in other states who had no clue about how to allocate these funds. Texas has multiple programs, and so it's like Africa and Atlas and CHIRP, and so it's like, oh, okay, we got a lot of programs that I now need to learn. I learned a new one actually today. The CEO and I are like, what is this program? And it's like, oh, it's one we decided not to participate in. So it's, it's like, okay, another acronym. But
right, it was wow. And they all probably mean something like completely insane.
Well, somebody
was trying to really get those. They probably used AI to get those letters to line up to make a word out of it.
Well, you know what? If you can do it, you can do it, right? So
that's right.
So, but yeah, so I think the issues in healthcare are the same wherever you go. It's the magnitude of which one is the highest issue, depending on the market you're working in. It also depends on your workforce, which is your biggest spend. Do you have unions? Do you not have unions? Do you have ratio requirements by the state for nursing? And so you just have to learn the nuances. But core to it, delivering healthcare to people is delivering healthcare to people. And I like to round. I like to see what's going on.
Mm-hmm. You strike me as that. I feel like Kim's out there. She's got checking things out, and she calls it fun. This is fun. That's fun. I've heard you say fun so many times. I'm like, oh, Kim's a gal after my own heart. Find the fun where it is,
Yeah, exactly.
Don't wait for it to come to you. You got to go to it.
That's right.
Exactly.
Find the fun. Cool. So, Kim, when you do rounds, what are you looking for?
So for me, it's just observing. So if it's in the clinical spaces, I don't usually do it by myself because they don't usually want to see the CFO. They're like, what are you doing, right? So I'll do it with patient experience leader, the chief nursing officer, the COO, different leaders and I just really want to go around and see what people are doing. I like to see the environment because particularly as we're looking at capital requests or other requests, you can't sit in your office and go, no, why are you doing that? You have to have a concept of why they feel that this is an important request for them. So our ED is super busy. There's some renovations going on down there. Our campus is a little messy right now because we're taking down a parking garage. We're building a new parking garage. We have to shuttle the employees in. So the other day I went and saw all the remote parking lots, and then I actually rode the shuttle in just to see what it was like to ride the shuttle in. So
how was it?
Yeah, it was fun. It was a nice shuttle.
It was fun.
I forgot my supply chain guy actually did this over the weekend, but I told the supply chain guy that he had to kind of keep giving me reports on parking, and so he's been doing that because he's in charge of transport. But it's kind of just getting the feel. I haven't been out to all the sites yet because my first 3 months were budget cave activity, I call it. So I'm getting ready for all of that. But I'm looking forward to.
I'm thinking of it like the Bat Cave, but it's
Yeah, it is.
It's not as cool. It's
My
not as
office
cool.
is in the
Big
back of the
screens.
administrative suite with my assistant across, and it's just like, oh my gosh, I'm just like in a cave back here. I don't even know if it's light outside or not. So, yeah, so it's that way. But I do like to get out and about. I will do virtual rounding. That's another thing that I started actually during COVID. But because we have people who are hybrid or remote, I just randomly will call people up and say, hey, how's it going? All the way down to everybody who's in my area of responsibility. So I'll do that. I will round over where my staff sits. I will also participate in my leaders' huddles. We just had a decommissioning. We were trying to decommission some of our infrastructure last week. I participated with that to the team. I think visibility is important, so that they show that you know what's going on, you're supporting your team. I always tell my team, I will be in your space to support you, but if you don't let me in your space, I'm really going to be in your space. So they usually let me in knowing that, don't worry, I'm not trying to do your job. I'm just trying to figure out, I'm new, I'm trying to support you, and ask a lot of questions. So a lot going on, but I do like virtual rounding. So Teams has made that a great tool to just randomly call people up. It scares them, but when the CFO is going, but
I love it. I love it. Just
Listen,
call.
I think it
Be like,
scares
"We're not
anybody. You just
texting, we're
call
just
them.
calling." Yeah,
I just call
them.
people because sometimes like that's the easiest way to get an answer. Like you can text people or email them like you're waiting. Sometimes just like call people and they immediately think something's terribly wrong.
oh yeah,
And I'm just like, hey,
how's it
just
going
figured you
today?
could
Just
answer
checking
this.
in,
Yeah, exactly.
So no, it's
Yeah, my daughter's always like, I'm always like with Ava, Tina knows Ava, my oldest. I'm like, Ava, I gotta tell you something. And she's like, who died? It's like, no one's died. I just say every time she's like, who's died? Who died? I'm like, no, no one's died. What are you talking about? It's just, I guess, like every time, like, no, it's just, can you do this? And she's like, oh yeah, okay.
That's so
like,
funny.
All right. So Kim, when you step into a new place, I'm curious to know on your approach to the payers. You talked about being like still an issue. Like when you step into a new place, how do you establish A, get the lay of the land, and B, establish either relationship or I don't know directives with your your major payers? I'd be curious to know your approach to it.
Yeah, so I think the first approach is I try to figure how we work with the payers. Like, do we have JOCs with the big payers, or what mechanisms do we have, or do we just not have them, and then we give up and we write everything off, right? So every organization I come into, it's like understanding, the payer makeup, where the challenges have been, contract inventory, because I want to know where we are in cycles. I want to understand the history. I also want to understand the CEO's perspective on who's leading. Does the CEO want to be involved or not be involved? Does the CEO want to know when we're in negotiations so they don't answer the phone of that payer during that time? So we know that happens.
Nice.
So I've had some CEOs like, when we're in negotiations, I'm not talking to the payers. I'm like, that's perfect because we need to negotiate and not feel the pressure. I also want to make sure we have a strategy so that we've defined what our managed care strategy is. Are we going all in on MA? Are we only doing a few MA plans? What does the MCO, the Medicaid managed care plans look like in the market? Do we have them? I've had different ones. They function differently in different states. And then the commercial strategy. And the commercial strategy is not only just for the employers and the businesses, but the ACA strategy. And so then which I recently have done, is work with my board and let them understand what it's like to have a managed care strategy, the one I'm defining. And that includes giving payers notice. And perhaps their next door neighbor coming over and saying, your hospital is going to be out of network in 2 weeks and I can't go anywhere else for care. And preparing the communication plan, I call it, all the way up through the board members about what it means to negotiate, to get the right rates based on the market and making sure we're getting paid appropriately. So as I go in, it's the landscape, it's the strategy, and then making sure everyone understands the communication on the strategy, and then who's leading. So it's tough, and it's not a 60-day activity. It'll take about a year or a cycle to get through all of this, because as you know, it's about 180 days to give notice. And you have to work through the pain and agony and discussions with the payers. And there's so much more data out there around the market and their rates. We also have to go through our own analysis, which doesn't always jive with the payers' analysis.
Shocker.
So, and so then that's the negotiation part. The other part, though, is rev cycle and the joint meetings, the JOCs, so that.
Do those really work anymore? Are those working?
You know what? It's yes and no. I think it depends on the payer. Some of the payers, I think the regional payers are more apt to still stay with it. When you get to the large national players, it's almost like how low am I talking in the organization, and what decision authority do you have? Because it seems like they don't have any decision authority. It's just, here it is. Here's the denial. We're always going to deny this. And so it seems like they're trying sometimes, and it's not everywhere, but some payers just try to exhaust you, so you'll just walk away.
I think some of it's like my experience with those is like a lot of like not passive. It's not even like maybe intentional passive aggressiveness, but it's very like nice in the meeting. Like, yeah, that's a good idea. We're gonna come back with like we're gonna move on that. Okay, let's do it. Like we're all in on moving whatever it is. And then a month goes by, we do another meeting, and they're like, "Oh, what was that again?" And it's like,
Right.
"Well, we didn't move on that, or we need so and so." And then what I find is like you'd make maybe a little progress, but like 6 months will go by, and then the person changes.
Yes.
Oh, that's a new job, a new role, and like, what was it you were working on? And I was like, what? Like, we just spent 6 months trying to get like somewhere on something. Again, they're big organizations. Again, I don't know if it's like fully on purpose, but I do think like in United's case, what my experience was, because we had a couple to my forums, Tina remembers this, we had a couple of really nice people, VP over a large region of the country, who would come to our forum, and they would, and like they would take feedback, and they would be able to interact. And I thought that was important. I thought maybe but what I found happening is like they just can't affect change. Like they could do something in their market, but the way that United divides it on purpose is that they cannot get any further outside their market. And so what they could do in like Colorado, they could not do in Arizona. If
Right.
that makes sense.
Right. And I think each of those regional people decides what's important. Excuse me. They decide what's important for each of those markets, right?
Yes.
So waiving their ED level policy where they use the Optum database instead of American Association of Emergency Physicians, American Academy,
Right.
So some markets let organizations waive that. Some markets didn't let the organizations waive that policy. And it's kind of like, so why are you allowing it here but not there? Well, it just depends on where the leverage is.
Yeah. Well, it's also like, I think to your point, like, who am I talking to? What level and authority did they have? Like several years ago, Class, good organization. I like those guys, but like they had this like payer provider summit, and they asked me to come, and I was like, so I'm there, and there's like, I swear to you, there's like 100 people there, and they probably had like 30 or so from payers. But I was in these like groups, and like we're talking, and I'm like, the highest level person in that whole place wasn't even like the VP level that we got at like our forum. It was like a director over like, and again, they're well-intended people, but they don't have any power. But you had like Matt Hawkins was there from Waystar. You had a couple CEOs of health systems, like big health systems. So the healthcare side is like, those people can make decisions.
Right.
but you don't have United CEO, you don't have a Aetna, you don't even have local regional and so I was like, what are you? This is again well intended, but I was basically like, my feedback was like, this is useless. Like this is going nowhere because you can't do anything with this. Like until someone at a higher level, a very high level on the payer side will actually like participate and actually commit to doing something, I don't know how you make any change.
No, I agree with you. I mean, they can make the little stuff, but you also have to look at the magnitude of who they're paying attention to, right? Do they pay attention to the single hospital systems or the small rules, or are they just, the people that are dealing with those facilities are definitely not there to make decisions, and those little facilities are barely making it, right? Not all of them, but some of them. But they do tend to pay attention to the bigger providers, the bigger bang for the buck, the larger revenue.
I will, and especially if they're like Kalamazoo is a good example. We use Kalamazoo. There's Borges and Bronson, right? There's two hospitals.
Right.
They basically have to listen to those guys in some way because it's the only people are going to service a big area. But I think if you're in like Dallas, there's probably 10 different like little health systems, big ones and smaller ones. And
well, like in Fort Worth, we have Baylor Scott and White, THR or TH, and HCA is here, and so it's, and then there's us, and we're the county hospital. Those three systems love the fact that we're the county hospital.
Oh, 100%.
So they do, because that's what we're here for, right? And so the payers don't look at it that way, though. They look at all four of us equal. And when you look at the four health systems that I just mentioned, including ours, we're not the big guy. So it's how do we get their attention? We do have the leverage because we are taking care of a population that needs us. So
yeah, and I would say, but you're right too. Like the impact of like you have 20% of your total revenues coming from something like that. The impact on a United or on like a smaller payer negotiation isn't as large as Baylor Scott and White, which is going to be enormous.
Right. And in the end, patients have choice. Where their doctor wants them to go, or their employer is narrow networking them.
Do you really think they have choice? I don't think that's real.
I don't
think that as a patient, I would suggest to you, I do not feel like I have a choice.
Really? Why do you say that, Tina?
Because I feel like it's hard enough to get the first bill paid, right? And then say you're recommended to go to someone else. And if I don't want to go to that physician, or say I meet them and I'm like, yeah, you're not for me, because I'm also a very specific, pure person, not general, specific. So then so is my choice. My choice is the guy that I don't like, or no care, right? Or care I have to pay for out of pocket. Like so is that really, is it really like a balanced and fair choice? I guess is probably the better way to look at it. Sure, it's a choice, and I have to decide which I'm willing to suffer through.
You're saying you're choosing your physician. You're saying you're choosing your physician, and then your physician is the one that's at Henry Ford or at Beaumont or Corwell. Sorry.
One of those.
I liked it better when it was Beaumont.
Let's not have that
campaign.
I think, Tina, to your point, though, so a lot of people, whether you're in the ACA or whether you're on commercial insurance, your plan is going to dictate the network that you have access to, right? So depending on how much.
But I also don't get to necessarily choose my plan, right? I mean, not me personally, because I am a self-employed human. But say I work for an employer, like they chose my plan. And they're choosing it based on a very different set of factors than the factors that I would choose for myself.
Right. But
so,
in the end,
again, I'd like the idea that there's choice, sure, but there's consequences, I guess, is maybe the better way to look at it.
No, and I see both sides of it. But I think overall, if you're seeing a physician and he says, I'm going to send you to the surgeon, or let's say not you, but if a woman's having a baby,
anyone.
They're going to want to go where their physician is comfortable delivering that baby, right? So does the patient have a choice? Sure, they can say to the physician, I don't want to go to hospital X because I want to go to Y because of my coverage. So it's some choice, some not choice. So I can see.
Yeah, exactly. Well, I just feel like again, like you choose using having a baby as an example, like you choose your doctor, but that doesn't necessarily mean that's a person delivering your baby. I have the same doctor for 3 kids. I had 3 different doctors deliver my children. So so again, it's like, am I getting what I really chose? Not necessarily, in the grand,
right.
scheme of it. I mean, I feel like we're using choices like,
well, I probably have another, like, there's another part of this where I think, Kim, I'd be curious to your take. I think part of this also is the hospital's fault, where most health systems now, they used to be a hospital. And I'm not picking at Beaumont, but let's just use Beaumont as an example. It used to be Beaumont here in Detroit. There was loyalty to Beaumont. Now Beaumont's merged with Spectrum, and it became Corewell, and now it's even bigger. And Henry Ford's the same thing, right? They start buying up these large, they become enigmas in a way, because they're these large corporations now. So I think part of it is like, well, health system, hospitals used to be like the largest employer, used to be kind of like a place that everyone would know and like would be super loyal to. Now I think that still exists to a degree. Don't get me wrong, but it's not the same as it used to be. Now it's like a good example is like the Cadillac, right? In Cadillac, it used to be Mercy, and that was, well, now it's part of some larger system that maybe they have no attachment to. Now they don't have any choice in Cadillac, but
there's one.
I guess my point would be just like they've become more of an enigma versus like, I have to go to such and such, because that's where I've always gone. And I don't know if there's that much loyalty anymore. Like, there's more loyalty to your position probably than anything else.
I think there's a couple of things to consider in that. One is the generations, right? So the younger generations, whether you're talking about Gen Z or whatever, the loyalty isn't there because they didn't grow up with the community hospital. They grew up with networks, right? So I think if you're looking at baby boomers, you may still see that loyalty because they grew up with that hospital and their kids were born there or their parents were born there, or, however old it was. Like, we have a lot of employees here that were born at JPS. It's amazing.
Right.
And
right.
but I think it depends on the generation on how that loyalty is perceived, because I think as you get in the younger generations, they just want healthcare when they need it. And so the loyalty isn't there regardless of if it's a local hospital or a big system, unless it was ingrained in them as a child, some through what they were doing. As when you're talking though about as the systems get bigger, the bigger systems or even the systems who are regional, as long as they remember that healthcare is still local and they keep the flavor, I think that's a really great benefit to having a larger system support your infrastructure. Bigger's not necessarily better, by the way, in my opinion. Doesn't always save you money. But I think having that infrastructure support so you can bring the latest technology and be forward thinking around delivering healthcare is great, but they still need to remember that healthcare is local. If they can remember that, it's still an employer in the community. It's sometimes one of the top 3 employers in the community. And remember that healthcare is local, and they have to build that around their brand and their community, even if their name keeps changing. So I'm not as familiar with the Detroit market anymore. I haven't been there for a while. I'm aware.
Sorry, we're just using, and I'm not picking on them.
Yeah, I know. Yeah,
but I think to your point, Kim, I don't think, and again, I was born in a Beaumont hospital. I had my children in a Beaumont hospital. And I was like, because I remember those campaigns. Like, I was very much like, oh, this is where I was born. And so I'm going to be loyal, right? To Ben's point, like that was my point of loyalty. But then when all of those mergers happened and the hospital, what appears, it's like it changed hands many times. It's like your favorite restaurant has had, 5 different owners and now the food is God knows what.
That's a little bit like that. I agree.
But I think that's how I, like that I feel. And I don't think that Corewell, did a great job in keeping that local idea, like I don't really feel like I don't have that sense of
what is hard
continuity
to do
in history. No, for sure. But I feel like maybe it's just like the renaming or the I don't know. I just feel like I feel like they could have done a better job. They need a better marketing company.
Well, and I think to your point,
I
like when I was with one larger system, they tried to rename all their locations with their system name plus the local name. And it was,
Mm-hmm.
I don't think it helped the brand in any way, shape, or form. It was just consistency, right? So even not picking on Corwell today in our conversation,
No,
but having
I
grown
know.
up in
Yes,
Grand
sorry.
Rapids, I'll pick on them for a minute.
Right.
They had renamed themselves Spectrum, and nobody liked
Mm-hmm.
it. It was Blodgett
Yes.
and
From
Butterworth.
Butterworth and Blodgett, yeah.
Right.
Yeah.
And I grew up as a Butterworth brat. My dad that's where he practiced. And now it's, Spectrum Butterworth campus. They use both names now. And I think sometimes remembering that there's a lot that aligns with the local culture, right? Why change the name? Is changing the name really going to mean healthcare is better?
Right. Who's it for? It doesn't seem like it's for the patient, like the name
Right.
changing.
Maybe
to
it
your
should have
point.
been like Butterworth Hospital, a division of Spectrum Health or
Spectrum
something.
Health,
Just like
yeah.
the legacy in the community is so much more important. And the people are still there. The people are still there. But that,
Right.
that goes for any large health system that's coming in. The system wants the recognition that they're now part of a large system, right? The system wants that recognition. And so how do you keep healthcare local?
Right. Well, I think too, like in one of our early forums, I want to say it was when we were in Denver, Ben.
Whoa,
Someone
okay.
came and did a presentation about building brand loyalty with patients. And my favorite comparison always is using Disney as the comparison to a hospital stay. And I'm like, you guys got to stop this. It's not the same thing. Like you can't create a Disney experience because it's not fun. Like we're not going there to have a good time. It's not a vacation. And also it costs more than Disney. So I always find that like really intriguing. The branding aspect of healthcare is, to me, as a person who works and has worked in marketing for many, many years, to think of how it seems like an internal thing, like how internal people at a hospital think about that outward message and what it should be for attracting patients. I think to your point, it should be about community and care, but it seems to be morphing into something else that really doesn't make sense to me personally, but maybe I'm an outlier.
So I think you're asking the wrong person, Tina. Asking the systems to answer the CFO about marketing, although some people
I know. Sorry, you're just like, I just pay that bill and I don't like it.
I don't like it.
I don't like it.
I love it. You brought the CFO into a marketing conversation. I love that you brought a CFO into a marketing conversation.
I'm sorry, but yeah,
I know.
No,
well,
it's
you're still a patient. You are a person who partakes in healthcare. So, I mean, the message is the message received. So
it is the message received, and I have lots of opinions about marketing and healthcare and making sure that it's aligned with the community. That's it's a lot. It's like understanding the why and where we're going, right? And so if I want to use you, why should I use you, right? So I'm a big why person.
On that.
Right.
Yeah. I agree with you. Like Salome, I remember, well, I have lots of thoughts, but that's not either here or there. But I agree with you. Like it really should be about community and care and a feeling, right? Like evoking this feeling. And instead it seems to be very much about like name recognition and when in the moment, if you need healthcare, you're going to go to, the nearest, I would assume the nearest location, depending on the urgency of your situation.
Exactly.
All right. Well, Kim, I can't thank you enough for doing the podcast and continuing on the mission. And you're getting back out there and doing some amazing work where it's needed. It's fantastic. Thanks for telling your story and being vulnerable. I appreciate it, especially about your dad, which was great. I appreciate you doing that. And thanks for joining the show. So good.
Absolutely.
And you guys have been great.
Thanks for spreading your light.
Thank you.
Right. Exactly.
That's right.
And one of these days we had to get you to forum and you can talk. So
okay.
I'll get you there one of these days.
Happy to do that. And, I think my team will tell you that I weekly check me out on LinkedIn though. Check all my little weekly videos. So probably didn't talk about that, but.
Oh yeah. Yeah, for sure.
On LinkedIn,
follow Kim on LinkedIn.
That's right, people.
Yeah, follow me on LinkedIn. Please cut that out of this, by the way.
Put a link in the bio. We'll put a link in the
We'll
show
put a
notes.
link in the bio. How's that? We'll put a link in the bio.
That's fine, but I guess for the story I was going to tell you is every Sunday night I think about what I'm going to reflect on for the week. And then
You do that every week?
I do it
That's
every
crazy.
Sunday night. It's like, what am I going to reflect on? And so I then create the topic and I use my AI and create a little video. And then on Friday morning it posts and it reminds me, like, did I do what I thought I was going to do this week?
Oh.
So this week will be on
That's
joy.
cool that you're using your own messaging to support your journey as well as many others. That's
Right.
cool.
Right. The last 2 weeks have been on football themes. Like, what's your next play? From interception to touchdown, what's your next play? Learning as you go forward. But this week's joy. So,
Cool.
but yeah, it's just my way of personally reflecting for myself, but then outwardly sharing it.
No, it's fantastic.
Awesome.
Yeah.
All right. Thanks, Kim. We'll
right.
we'll talk to you soon.
Okay. Thanks, you guys. Have a great day.
Thanks so much. Yeah.
Thank you.
Bye.
Bye.